Good afternoon, ladies and gentlemen. Welcome to this seminar on immunotherapies for psychosis and depression, where we're going to try and answer the question as to whether this is a promising new lead in this area of increasing interest in the interaction between the immune system and the brain, or whether it's yet another blind alley in terms of new therapeutics. So we've got 4 talks. It's a great shame that the convener of this symposium, Golem Kandekar, is unable to join us because he lost his passport. So fortunately he was allowed back into Britain, but he isn't being allowed out again just at the moment. So I'm going to take his place in presenting the second talk, but it's a pleasure to introduce Valeria Mondelli from the Institute of Psychiatry to give the first talk on inflammation and response to antipsychotic treatment. Valeria.
Thank you very much for the introduction, and it's a pleasure to be here to present some of our data on inflammation and psychosis. So what I'm going to focus today is a bit of our recent published results on inflammation and psychosis, trying to understand where is this inflammation coming from, and also is this important for our patients. So before I start, let me acknowledge the people who contributed to some of the data that I'm presenting today, in particular David Bamester, Marco Di Nicola, Nilay Hepgol, all the researchers from the GAP study, and the senior collaborators. I work with Professor Murray, Professor Dazan, Professor Pariante, and all the funding agencies which have supported the study so far. So why inflammation and psychosis? So we know a lot from the recent publications in the last 20 years that elevated levels of inflammatory markers are found in patients with schizophrenia. And this is just a mention of a very nice meta-analysis from Brian Miller, published now already in 2011. We more recently also looked in particular at studies looking at inflammatory markers in patients with first episode psychosis. And as you can see, both in the chronic schizophrenia and in the first episode psychosis, we can find some elevated levels of pro-inflammatory markers such as interleukin-1 beta, interleukin-6, or TNF-alpha. But where is this inflammation coming from? So one of the things that I've been very interested in is stress. So why stress? Well, we know from now quite many years that stress has been recognized to be associated with the development of psychosis. We know from different studies that recent stressful life events can precede the onset of psychosis, and this has led also to the development of a vulnerability stress model where we can think that some subjects are more biologically vulnerable to stressful events, and this then contribute to development of psychotic disorders. And of course, a substantial number of population-based studies have also suggested that childhood traumatic events can be also a risk factor for psychosis. And why inflammation? Well, we know now also more recently that stress can activate the immune system. And of course, this activation of the immune system has an effect also on the brain. We know that the inflammatory mediators, such as cytokines, can alter the metabolism of monoamines, and that can increase the excitotoxicity in the brain and decrease the production of trophic factors. So we know that the activation of the immune system can have an effect on the brain as well. So really what I've been trying to look at in the last few years is this inflammation that we find in the patients with first episode psychosis due to the excess of stress that we see in these patients? So here are some of the data that we published already quite a few years ago. And here you see the patients with first episode of psychosis in the red column and the healthy age and gender matched controls in the blue column. And we just measured one of these inflammatory markers, that is tumor necrosis factor alpha. And you can see that the patients tend to have a higher level of this marker. What was interesting when we look at it more at this data is that if you divide the patients with experience of childhood traumatic events and the patients without experience of childhood traumatic events, you see that actually are the patients with the childhood trauma who have the higher levels of TNF-alpha compared to those who do not have this experience, suggesting that maybe not all the patients have this high inflammation, but maybe those who had more childhood traumatic events are the ones who present these increased inflammatory markers. And we did something similar by looking at another inflammatory marker, which is C-reactive protein. This is a protein which usually increases during an infection. Again, is a marker of activity of the activation of the immune system. And as you can see again here, the patients have a higher level of C-reactive protein when compared with the healthy controls. And what we did, again, we kind of trying to break down, again, patients with experience of childhood sexual abuse, the patients without experience of childhood sexual abuse in green, and the healthy controls in blue. As you can see, again, we have actually increased levels of the inflammatory marker, in this case is the C-reactive protein, in the patients who had the experience of childhood sexual abuse. Again, supporting that probably the experience of childhood sexual abuse might have a role in this increased inflammatory marker later on in our patients. So to try to confirm this data and understand a little bit more about this, we have just recently published a meta-analysis of all the studies who looked at inflammatory markers, in particular C-reactive protein, interleukin-6, and tumor necrosis factor alpha in adults, where they also looked at if they had experience or not of childhood trauma. So this, just to clarify, this was not a meta-analysis of only studies focusing on patients with psychosis. This was including studies who looked at childhood trauma and adulthood inflammation across different psychiatric disorders, so also including depression, but also just looking at those studies that look at healthy controls, also general population, or other patients with medical disorders. And what is interesting is that the data from our meta-analysis show elevated levels of all these three inflammatory markers, so elevated levels of CRP, interleukin-6, and tumor necrosis factor alpha in adults with a history of childhood trauma. So this is interesting because in a way it says that the childhood trauma might, in a way, prime, if you want, the person to have an increased inflammation in adulthood, and if something happens maybe later on, this might contribute to the development of a psychiatric disorder or of a medical disorder. Is this important for the brain? So another thing that was quite interesting is that we saw that the activation of the immune systems can have an effect on the brain, was to try to understand if this was also responsible for some of the alterations that we see in the brain structure in our patients. And I focus in particular on the hippocampus structure because we know that this is one of the most consistently reported brain structure, which is reported smaller in patients with chronic schizophrenia, and also in first episode psychosis, although this is usually the left side hippocampus. So in the same patients in which we measured the inflammatory markers, we went to measure the volume of the hippocampus. And then we did a correlation analysis, and as you can see, we found a negative correlation. So as you can see, the higher the interleukin-6 levels, the smaller the hippocampus in our first episode psychosis patients. Again, suggesting maybe that the inflammation may play a role in the development of this shrinkage of the hippocampus. So these are some of our more recent data, and the other thing that I was quite interested in, it was to try to understand if this could be important also for the physical health of our patients. So what we did in our patients in which we measured the inflammatory markers, we measured also metabolic status, looking at weight, body mass index, lipid profile, glucose, and glycosylated hemoglobin. And then we followed up the patients after 3 months, and we look at the same measurements again. So what we were quite interested in understanding if there was an increase in the inflammation over the 3 months, if this was associated with a worse kind of a metabolic profile at 3 months. And as you can see here from the graph, we found a correlation between the increase in triglycerides levels over the 3 months with the increase in the C-reactive protein. So patients with increases in this C-reactive protein over the 3 months were the ones who also were increasing in the levels of triglycerides. And because we know that this might be due also to weight and body mass index, as you can see, in fact, we did a regression analysis. As you can see from the first part in the linear regression, also the variation in BMI or in weight was predicting the increase in triglycerides, which is you would expect that. In the hierarchical multiple regression, in the second model, we put both the variation in weight, the baseline CRP, and the variation in the CRP level over the 3 months. And as you can see, is the variation in the CRP, so the increase in CRP over the 3 months, which is the main predictor of the triglycerides levels over the 3 months. So in some way, these are still preliminary data because the samples was quite small, was only 53 patients. But it seems like the patients experiencing the greater increase in inflammation early on in the course of their illness may be at a greater risk of developing the short-term metabolic abnormalities, in particular those on the lipid profile. And this seems also possibly to be independent of the weight gain. So finally, is this important for the clinical outcome? So what we did in our patients, in which we measured the different inflammatory markers at baseline, we followed them up as we did also for the metabolic outcome, and we look at instead at 3 months follow-up if they were responding or not responding to treatment at 3 months follow-up by using the Andreasen criterion for remission. So here in this graph, you can see the patients not responding to treatment at 3 months follow-up in the red column. In green is the patients who are responding to treatment, and in black are the healthy controls. So as you can see, these are interleukin-6 levels measured at baseline. And the interleukin-6 levels were higher in those who are not going to respond to treatment at 3 months follow-up compared to the healthy controls, but also compared to those who are responding to treatment. So this is very interesting because these are the baseline interleukin-6 levels, and we measure the treatment response at 3 months. So in a way, it's telling us that the increased inflammation is predicting who is not going to respond to treatment after 3 months. And this is true not only for the interleukin-6, but we looked at also other inflammatory markers, for example, the interferon gamma, and we found a similar effect. So the interferon gamma levels were higher in those who are not going to respond to treatment at 3 months follow-up compared to the responders and the healthy controls. So this is interesting because, in a way, from all these studies, we see that inflammation is increased, probably not all in all our patients, but maybe in a subsample of those, and that this might be important for the treatment response. So if this inflammation is increased and is contributing to the response, to the lack of response to the conventional treatment, can we use then the anti-inflammatory treatment for these patients? And I think, in a way, what our findings are supporting is this is very important when we are designing clinical trials with anti-inflammatory drugs, because we need to think about possibly targeting only the patients with increased inflammation, as we see that not all of them have increased inflammation. And we see this in particular already from trials that have been conducted in patients with treatment-resistant depression. And this is a very nice, elegant clinical trial done by Rayson and Miller. And they looked at basically adjunctive treatment with the TNF-alpha antagonist infliximab in treatment-resistant depression. If you can see from the graph, in the overall sample, actually placebo was doing better the anti-inflammatory treatment. But when they stratified the sample on the basis of the baseline CRP level, So the patients with the higher CRP levels at baseline were the ones who were getting benefit from the anti-inflammatory treatment. So this is not only important because it's telling us that we should probably target only those with increased inflammation for having an effect, an effect with the anti-inflammatory treatment, but it's also telling us that possibly a certain degree of inflammation might be beneficial and neuroprotective, and we shouldn't probably use anti-inflammatory treatment in those who are not inflamed in the first place. So just to conclude, we saw that childhood trauma seems to contribute to the increased inflammation in adulthood that we see at the onset of psychosis. The increased inflammation seems to affect the brain function, the brain structure, in particular the hippocampus, and the physical health at the onset of psychosis. That the increased inflammation also predict poor treatment response at the onset of psychosis, and this may be very much relevant for future clinical trials using anti-inflammatory drugs, in particular with the idea that we should probably target the right patients that are those with increased inflammation. Thank you very much for your attention.
Now it's working, yeah. Thank you very much. Now we're here. I think it was a very interesting presentation. I think there are several clinical implications that can be drawn from this. I wonder if somebody wants to ask a question. Come to the microphone.
Thank you. When you look at the CRP levels that you might consider to be high, if you're thinking about who's more likely to respond, it's still very low levels, isn't it? So we're talking difference between 1 and 3.
Yeah, sure. I mean, we are not talking about inflammation as we would see in an acute infection. We are talking about a chronic subthreshold, if you want, inflammation. But it's interesting because the threshold that we are starting now to use for the clinical trials, for example, for depression, is the 3 milligrams liter that are the same ones that we are actually using for, for cardiovascular risk. So it's interesting that we are possibly using similar threshold across different type of disorder. And it seems that in the clinical trial for depression, this is actually making the difference.
And CRP is the best one. There isn't any more that are more sensitive or.
So we are using the eye-sensitive C-reactive protein levels, yes, to look at that. We are talking about. As I said, it's not the inflammation that you would expect during an infection. We are talking about very low levels, but it seems that make a difference in the long term.
I mean, this is an issue, isn't it? Because the immunologists laugh at us when we say inflammation with a CRP level like that and don't want to know. And in fact, you can't get them down to see anybody much when we're looking for these autoimmune sort of phenomena in patients. Would it be better to be calling it immune activation and not to try and pretend that this is true inflammation? I mean, it's a very inflammatory word, and I think it puts us at risk of actually not actually, whereas if there is some form of low-grade immune activation,
absolutely,
that would make more sense. But I think there's a lot of people who criticise us for using the word.
I know.
Especially on those low levels.
It's true. I mean, it's something that we talk a lot with our friends immunologists, and it's true. It's an immune activation, and it's not a real inflammation. We should probably start to talk about it as immune activation rather than inflammation. I agree.
Okay, I think there are several questions, but we will not have time for it. So it's my duty now to introduce my co-chair, Peter Jones, who is a professor at Cambridge University, and he is here to replace Gholam Khandagar, who couldn't make it, but Peter will give his talk, and I'm sure he can do it well.
Thanks very much. Good afternoon again, ladies and gentlemen. So, in this talk I'm giving on behalf of Gholam, part of it will link over what you've just heard with Valeria Mondelli, and part of it is going to be more to do with depression. So I've got no competing interests, but I'm up here wearing the feathers of many people, particularly Gholam, and the work that we've put into this has been supported by largely through the Wellcome Trust and the Academy of Medical Sciences. So the two parts to the talk. One is thinking longitudinally about the association between IL-6 levels and subsequent depression and psychotic experiences, and also thinking developmentally about depression in terms of persistence. And then I'm going to go on and talk about a recently published systematic review and meta-analysis looking at the antidepressant effect of anti-cytokine drugs. So I should have declared an interest in that, of course, I'm not an immunologist, but I will be very careful to talk about low-grade immune activation rather than inflammation. And in fact, this is a point that trips up us as psychiatrists and many people in the audience thinking about what we mean by inflammation here, systemic inflammation. I know immunologists may have trouble, but this is exactly the same sort of debate that goes on in cardiovascular disease epidemiology or diabetes, for instance. So we've got to think about the immune system as two large compartments, innate and adaptive, and what I'll be talking about is the innate or rapid fire immune system, and Belinda Lennox later will talk about the adaptive compartment. So pro-inflammatory cytokine levels are elevated in depression. You've already heard some evidence from Valeria about that, but the direction of causality is not necessarily clear. And you've seen some evidence about cross-sectional studies of cytokines and depression. So this is another view of that. This is a cumulative meta-analysis. So looking at the way subsequent studies shrink the effect size. And this meta-analysis looked at a range of cytokines, but here I'm showing you some data for IL-6. And the first study is at the top, and the comparing cases of major depression and controls, and the line of no effect is this vertical line here. And you can see that many studies have shown that this is an effect size of higher IL-6 in major depression in cross-sectional studies of people who are ill at the time. And cumulatively, we now have a very precise estimation of the average effect size of increases in IL-6 and major depression. Valeria's already mentioned the meta-analysis by Miller et al. In terms of psychosis. And here we've got each row, each pair of horizontal bars is a different cytokine. And red is acute psychosis, and to the right are higher levels, to the left of the vertical line are lower levels. So red is acute psychosis, blue is first episode psychosis, and green is following psychiatric treatment. And you can see that for pro-inflammatory cytokines like IL-6, TNF-alpha, and interferon gamma, that in acute psychosis, first episode psychosis, these cytokines are raised, and then they're normalized with treatment. But for an anti-inflammatory cytokine like IL-10, the effects are opposite. Now, cross-sectional studies only go so far, so could this be causal? And you've already heard from Valeria some longitudinal thinking in terms of prior traumatic experiences and inflammatory cytokines. What we did was to use a longitudinal study, a birth cohort study called ALSPAC. This is a study of initially about 14,000 people born in and around 1991 in the southwest of England. And when they were 9, they had IL-6 and CRP measured in about just 4,500. And I can remember being in a planning meeting for what was going to be included in the age 9 data collection, and I said that they should collect some psychiatric measures, which were let in, and the cardiovascular people were saying, well, we must measure cytokines. And I remember thinking, God, I wish we had something like that for psychiatry. And of course, that was some time ago now, and it looks as though we're riding in on the coattails of the cardiovascular people. 9 years later, ALSPAC birth cohort collected some psychiatric outcomes, so psychotic experiences, using the PLIX interview, and a psychotic disorder definition made by Stan Zamet, and depression that was measured in a number of ways. And here we're using a definition of depression from the CIS-R, Clinical Interview Schedule Revised, which is a fairly regular population-based measure of depression. And a number of important confounders, so gender, social class, ethnicity, maternal, Edinburgh Depression Scale score, looking for postnatal depression, SDQ, Strengths and Difficulties Questionnaire, to get a handle on childhood, prior psychological state, and body mass index. And what Golem did was to divide the population distribution of IL-6, having taken out all the children who declared a recent infection. So taking the population distribution of interleukin-6 minus those who had an infection and divided it into thirds or tertiles, and then looked at the relative risk of depression, psychotic experiences, and psychotic disorder in those thirds of the distribution of IL-6. And you can see that there are evidence of some linear increases in risk across the distribution of IL-6 at age 9, increases in risk for psychiatric disorders at age 18. And that survived adjustment for confounding for those alternative explanations like BMI, gender, etc. So a transdiagnostic association between childhood IL-6 and early adulthood depression and psychotic experiences and psychotic disorder. Now, that's taking a fairly crude case control approach, even though it's in longitudinal data, just taking a cross-sectional view of psychiatric state at age 18. But in this longitudinal study, the children actually had many assessments of anxiety and depression. And on the x-axis here, you can see that there were measures of depression and anxiety taken at 10, 13, 14 years, 17, 18, and 19 years. And at the top right-hand corner, there is a picture of Jan Stockel, who's a psychometrician. And what Jan did was to apply a longitudinal trajectory class analysis to these data and found good evidence that there were, if you like, 3 common ways in which the teenagers in this study either went through depressive and anxious measures, so 3 trajectories in terms of depression. And the most common trajectory in the green line at the bottom is having virtually no symptoms. Then you've got a group in red who have persistently high levels of depression. And then a group in blue, which is intermediate, so they go into puberty without depression and then they accumulate depression over their teenage years. So 3 groups. And we hypothesized that this would be a rather harder test of the association between childhood IL-6 and later risk of depression. And we hypothesized that lower levels of IL-6 would be associated with the persistently well group. And then there'd be a dose-response relationship in the adolescent onset and then a higher association with the persistently depressed. And if the slide will go on. I'd rather move forward. So you can see this is what we found. So these bars now are the linear associations on the left with IL-6 and no adolescent depressive symptoms, and then a non-significant, slightly raised association between childhood IL-6 and the adolescent onset depression, and a higher statistically significant association between IL-6 and persistent depression during the adolescent years. So we've got a longitudinal study, ALSPAC, that I think to a considerable extent excludes reverse causality. It's not just the depression causing raised cytokines, it's raised cytokines 9 years before the measurement of psychiatric disorder, and also perhaps a more interesting association in the way that the adolescents with higher IL-6 accumulate their depression. It's early and persistent. So if you think that you're looking at something that may be causal, and epidemiologically, of course, that's a very fragile concept, the question is whether if you change the IL-6 levels or cytokine levels, would you affect depression? And there are many ways to approach this. And this is, I'm just going to show you some slides of a paper that was published earlier this week, so I won't have got any sort of circulation yet. The picture here is of an extremely bright and creative master's student who came over to Cambridge from Maastricht, called Niels Kappelman. And Niels undertook a systematic review and meta-analysis of studies of autoimmune disorders, largely rheumatoid arthritis, where they'd used large molecule monoclonal antibodies to treat these autoimmune disorders, as I say, largely arthritis, and had identified studies where depression had also been measured before and after treatment. So the key questions were, does blocking a specific inflammatory cytokine lead to improvement in depression? And the cytokine largely we're talking about here is TNF-alpha. And what's the relationship between the antidepressant effect and the effect on the physical disorder? So if you've got a painful condition, for instance, if you treat it effectively, depression may resolve because you're in less pain. So Niels tried to examine that statistically. So he looked at clinical trials of monoclonal antibodies in these inflammatory conditions, looked at a range of databases, the usual places one would look, identified 350 potentially relevant studies, and then whittled them down, as you can see, to 20 included in the review. And the most important ones were randomized, double-blind, placebo-controlled trials. And here's the summary slide. So adalimumab, which is an anti-TNF-alpha molecule, 2 studies. This is the vertical line of no effect. This is an antidepressant effect. So the comparison of before treatment and after treatment. And you can see the pooled effect here is for an antidepressant effect. Similarly for etanercept, again anti-TNF-alpha. Pooled effect for an antidepressant effect. Here's the Raisin et al. Study that Valeria mentioned, where there was an interaction between whether people with depression had higher levels of inflammatory markers when they were treated with infliximab. And here's the Raisin study you see as an outlier, but overall we've got a pooled effect showing an antidepressant action of these anti-cytokine molecules, very specific anti-cytokine molecules. But the $64,000 question is whether that was mediated by a reduction in pain or other symptoms. So one way to approach that, not the only way, is a meta-regression, where you include the effect size of the improvement in physical symptoms. Okay, so you can regress the antidepressant effect against the improvement in physical effect and see whether there's any antidepressant effect that is left. And basically, what you see on this slide is the meta-regression line, and the contributory studies are weighted according to their size. And although there is a small potential contribution of improvement in physical symptoms, as you would expect, it's non-significant and only small. So to summarize what I've presented here, so inflammation, particularly cytokines, seems to contribute to the pathogenesis of depression and psychosis. Careful use of wording here, higher IL-6 levels in childhood are associated with increased risks of depression and psychotic experiences and symptoms, and also persistence of depression during adult life. And that longitudinal association suggests causality. And when we did a systematic review of very specific anti-TNF alpha treatments, anti-cytokine treatments used in physical disorders, there appeared to be an antidepressant effect that couldn't be explained by any changes in physical symptoms. So thank you very much.
Thank you, Peter, for this very interesting presentations. I'm sure there are some questions from the audience.
Thank you. I just wanted to, I'm Kelly Ellett from Melbourne. I just had I don't know this area of research at all, but I just was wondering about the mechanism or the causes of the increased inflammatory markers. So the earlier speaker mentioned stress and childhood trauma, but are there other factors like diet, or, that might be a naive question, but what causes this sort of raised levels? What are the theories?
Yeah, well, the slightly disappointing answer is that many things appear to. So you heard in the previous talk about childhood trauma in the general population and the meta-analysis that was shown. Another master's student we had working on ALSPAC also showed that in ALSPAC that a range of early life adversities, including maternal depression, once we'd adjusted for all the alternative explanations we could think of, increased IL-6 slightly, or was associated with higher IL-6, so a range of adversities. Then, of course, there are genetic associations. So there are genetic variation at the IL-6 receptor site, and that's quite important because you can then go on to use Mendelian randomization to show that do people with higher IL-6 levels, because of their genetic endowment, which is of course distributed randomly, do they have higher levels of depression? And the answer to that is another talk in Boston in 2018. But it's very exciting.
Okay.
Peter, has it been explored if there's a relationship with autoimmune disorders and these increased inflammatory markers? Because it seems like that would be a likely case in folks with in the specific areas that you're looking at, so in psychosis and depression.
There are associations between autoimmune disorders and psychosis and depression, yes. And people with autoimmune disorders do have massively raised levels of these inflammatory markers. Yeah.
I think there'll be a final question. Where was it? No? It was actually before you. Okay.
Yes, I just wonder with the treatment of depression, were these patients already on antidepressants, and how was the monoclonal antibody administered? What sort of protocol was used? Were they one-off sort of subcutaneous injections, or how did you treat them with the anti-cytokine treatments?
Well, these are all randomized control studies of those monoclonals being used for largely rheumatoid arthritis, some juvenile RA and some adult treatment resistant. And they'll all have used a variety of standard protocols. Whether they were on antidepressants or not, I think one of the studies reported that, most of the studies don't. What we're using in that meta-analysis is really safety data. So data that the trialists didn't think was going to be particularly important, but because most of them are industry-sponsored, well, good trials, then they collect a range of safety data. Often it's suicidality that gets collected, because that's the big fear. But we identified these 20 out of 350 potential studies that had things like the general health questionnaire, some pretty simple measures of depression.
Okay. Thank you, Peter. And our next speaker is Belinda Lennox from the University of Oxford, and she's going to talk about evidence for effectiveness of immunotherapy in psychosis.
Thank you very much, Maretta. I was given the task by Golem of talking broadly about what is the evidence base for the effect of immune treatments, again with quite a broad definition in psychosis. So I will talk about autoantibodies and the treatment for those, but I'll also cover a bit more broadly in areas that I'm a bit less comfortable about. And there are people in the audience I'm well aware who are much better placed to speak to this, so I hope they'll help me out. I have no declarations of interest, and I get funding support from the NIHR, from the MRC, and from the Stanley Medical Research Institute. So, as Peter alluded, I'm moving on to more of the adaptive immune system and the evidence base that schizophrenia in particular, a proportion of schizophrenia, may be an autoimmune disorder. And this, again, Michael will cover more of the epidemiological evidence in the following talk, but there's pretty strong converging evidence that a proportion of schizophrenia is autoimmune, and this evidence comes from both genetic studies, from the large genome-wide association studies, with the Manhattan plot of the latest study showing of over 30,000 people with schizophrenia, showing over 100 loci, and with SNPs associated with immune system proteins. So in particular, the very large one there that you can see even at this magnification being the major histocompatibility complex. But also SNPs associated with B-cell proteins with CD19 and CD20, which are important for B-cell production of antibodies. Then there's the epidemiology that shows consistently, really, an association between schizophrenia and other autoimmune disorders. This is a study from a couple of years ago from the population of Taiwan showing an association with most autoimmune disorders, with the exception of rheumatoid arthritis in those with schizophrenia. And then there is, I would say, pretty consistent evidence of raised inflammatory markers of cytokines that you would expect in an autoimmune disorder, and this is referring Golem's review of a couple of years ago in the Lancet Psychiatry. So in reviewing the treatment data of what's known already about the effect of anti-inflammatory agents in schizophrenia, I've referenced Iris Summers' review a couple of years ago, which was a meta-analysis and found 26 randomized controlled trials of a range of different agents that have been tried in schizophrenia as adjunctive treatments. And the ones in reds are the ones that come out of the meta-analysis as having positive findings, and the ones in black are ones that have negative findings in this meta-analysis. And there are a range of, I suppose it's interesting to observe, there's sort of a range of over-the-counter compounds. They're relatively easy to take and administer, amino acids or naturally occurring hormones, or in the case of minocycline, an antibiotic. A range of different approaches, all with used as a putatively anti-inflammatory effect. And the positive ones, I suppose, I'd refer to the aspirin trials. I suppose it's worth noting that there were relatively few studies, and the populations that they're used in are unselected. So coming back to Valeria's point, it's really crucial as a field, I think, that we target these treatment trials on people that we think is most likely to be helpful, and an unselected group of people with psychosis. We're probably going to lose any signal, if there is one there, that we really need to stratify on the basis of some measure of raised inflammation, or some suspicion that there's going to be an inflammatory component to the illness to start with. But there is a small signal there that aspirin is helpful, and similarly with estrogen augmentation. N-acetylcysteine as precursor of glutathione. Actually, I saw there's a couple of posters here today, which was really interesting to see. So I would urge you to go and have a look at those. And the trial that's reported today actually showed that although there was no effect overall, if you stratify on the basis of baseline glutathione levels by spectroscopy at baseline, you can show an effect with augmentation with this compound. And the minocycline trials are also quite interesting. I mean, it's a unusual compound, minocycline. So it is an antibiotic, and it does cross the blood-brain barrier. And it's used as the theory that it's particularly helpful with negative symptoms, but wildly varying results from the trials that have been done to date. And I've heard Bill Deakin, who's the chief investigator on a couple of these studies, speak, and he talks about the difference in the profile of the patients that he treated, particularly in the two sites. There was one in Brazil and one in Pakistan, almost with sort of diametric opposite findings, which he thinks is on the basis of the patient profile at baseline. But overall, at the moment, there's no signal that minocycline is dramatically helpful, unfortunately. Okay, so it's worth, as I said, that the trials that have been done to date have been on a broad range of compounds that are generally quite benign, quite easy to take, and well tolerated. But there are no randomized controlled trials of the more potent immunotherapy drugs, the ones that we would use in other autoimmune disorders. So there are no trials of steroids, of chemotherapy agents like methotrexate or cyclophosphamide, and none of monoclonal antibodies such as rituximab or infliximab in patients with psychosis. So I think we really need to design and run these studies if we're going to provide stronger evidence that actually a proportion of psychosis has an autoimmune etiology. Okay, so the work that I've been doing over the last few years is treating psychosis as it occurs in the context of these neuronal cell surface antibodies. And these antibodies have been described in patients with encephalitis. It's been recognized in neurology for the last 15 years or so, really, that you will get patients that are profoundly, seriously unwell with life-threatening encephalitis who have these antibodies against these neuronal cell surface targets. And the relevance of them being on the cell surface is that, A, you can detect them, you can screen for them, and you can remove the antibody and treat the underlying disorder. So it was rapidly taken up into practice, the intensive immunotherapy regimens that treat these disorders as being the treatments of choice for these. I haven't said that in comprehensible English, I apologize. I suppose what I'm saying is it's changed practice in neurology. They give the treatments to remove the antibodies when they find them in the context of encephalitis. There have been no randomized controlled trials to establish that these are the treatments that are required. They've just done it. So, you have patients on intensive care units that they find these antibodies, they give them high-dose steroids, they give them rituximab, they give them plasma exchange. They see themselves that these patients get better, and that's enough for them to have implemented that into practice. So from the first descriptions of these disorders, it was recognised that psychosis is a key feature. This is a European case series of over 400 patients with NMDA receptor antibody encephalitis to show, and it's been replicated in other continents as well, that patients present to psychiatrists first. They don't present to neurologists, and they present with paranoid psychosis. And then over a period of 3 or 4 weeks, they inevitably progress in their symptoms to become a more sort of subcortical illness. So they develop a characteristic movement disorder, orofacial dyskinesia. They develop autonomic instability. They might develop seizures, although that's actually relatively uncommon, and they lose consciousness. So this is when it becomes life-threatening, and they then come to the attention of the neurology teams, and the diagnosis gets made. And they have shown, this is just observational data, but that if you treat patients quickly and you treat them intensively, then they get better. Now, the y-axis is the MRS, the modified Rankin scale, and this is a really compressed neurological scale of functioning. So 6 is dead and 0 is better. So if you're getting a change of a couple of points on a modified Rankin scale, that really is a dramatic improvement. It's from being in an intensive care unit to being at home. So they showed that if you treat in under 6 weeks, that you get a much better outcome. And if you treat with steroids and other immunotherapy, by which I mean the drugs that I've been talking about, like the cyclophosphamide or rituximab or those oazathioprine, that again you get a better outcome. So this is what has affected the treatment protocols that are used now. And again, these are data from Martin Titulaer to show in a further series of over 500 patients that, again, if you give a second-line treatment, it's better than if you just give one treatment alone, and it's better than if you don't treat at all. And this is the sort of the rate of relapse over a 2-year period. So the relapse is not nothing. So you would still get a relapse of about 10% in patients that you have treated aggressively. But it's also worth knowing that actually not everybody who isn't treated, people who aren't treated also get better to some extent. So it's not completely cut and dry. Okay, so a few years ago, we thought it was a sensible idea to look in patients with first episode psychosis to see if they also had these antibodies that have been described in encephalitis, and that might therefore be of relevance for treatment, for different treatment approaches for psychosis. And this was a small study we did in Cambridge, just to show that 3 patients out of 47 patients in an early intervention service had antibodies against the NMDA receptor or against the voltage-gated potassium channel complex. We needed to check that it wasn't something strange about Cambridge and that actually we could replicate this across England. So we've been recruiting patients from a first episode service with super acute psychosis. So our inclusion criteria are people with less than 6 weeks of treatment. And we recruited a control group as well that were age and gender matched. And this is the bottom line. We showed 8.8% of patients had antibodies against one or other cell surface receptor that is recognized as causing an encephalitic illness. So these were a range of antibodies. It wasn't just the NMDA receptor antibody, it was the LGI1 antibody, which is associated with the voltage-gated potassium channel complex. It was the GABA-A receptor antibody as well. Individually and as a group, it didn't come out as significantly different to the controls. we found a significant number of antibodies in the control group as well. But except for the NMDA receptor antibody, seemed to be the most specific. We did not find any cases in the controls. So if you add that to a meta-analysis, alongside all the other groups that have tested for these antibodies in a range of disorders, you find a small but significant increase in all patients, actually, compared to controls of the NMDA receptor antibody. Most studies have been done in first episode psychosis. Speaking to Faith Dickerson earlier, the strongest find is actually in her study of patients with acute mania, although it wasn't significant when you look when patients then got better, or in bipolar disorder as a whole. So it's possible that NMDA receptor antibodies are relevant for some patients with schizophrenia and maybe underline their illness, but really we need to take it forward, we need to answer the so what question, and we need to do a treatment trial to see whether removing the antibodies treats the psychosis. So for the last few years, we have been treating patients with psychosis in the same way as we treat patients with encephalitis. We have a joint encephalitis clinic that I run with a neuroimmunologist, and everybody with a clinically relevant presentation, whether that's with psychosis, whether that's with seizures, whether that's with encephalitis, and with NMDA receptor or other relevant antibodies, and who haven't responded to symptomatic treatment. We treat them according to the protocol that has been defined for encephalitis. So what do we do with people? Well, we do investigate them. We do lumbar punctures where possible, and we do MRI and EEG and neuropsychology. But actually, they're not the sort of critical factors, because many patients with encephalitis have normal MRIs and normal EEGs, will not have cells and antibodies in their CSF. That's not the sort of a critical decision-making factor. What's critical is whether they have a clinically relevant presentation and a significant level of antibody in their blood. And we offer them either intravenous immunoglobulins or plasma exchange as acute treatments to remove the antibodies, and we give them steroids as a first line. We give them steroids for up to 6 months usually, and then we taper that off and stop it. And for people that relapse with their illness or don't get better with that, we add on mycophenolate mofetil, which is an anti-rejection drug that's used after transplantation, an immunosuppressant drug, or azathioprine, or rituximab, a monoclonal antibody. So in looking at our clinical data samples, I suppose this is part of the reason why we don't discriminate between the symptoms that people present with, because we don't actually see an awful lot of difference in either their antibody levels or their response to treatment. So this is comparing patients with the full spectrum of encephalitis symptoms and the atypical restricted presentations. And actually they had comparable antibody levels at baseline, and the antibody levels went down with treatment. And in their modified Rankin scales, again, although they started at a lower level because they didn't tend to be on intensive care units to start with, they also responded to treatment in a significant way after immunotherapy. So that's why we don't distinguish patients with psychosis from patients with encephalitis. So this is a case series of our first 18 patients with NMDA receptor antibodies and psychosis. That we were young and naive back in 5 years ago. We took everybody that came with a positive NMDA receptor antibody test result who'd been tested in clinical services. Now, the reason they were tested was either because they were in the first episode service, and that's what we introduced into clinical protocol, or because they had highly atypical treatment-resistant illnesses, often with prominent catatonia, extremely severe unwell people. So it's a real mixed bag of presentations. And then of those people, half of them we offered treatment to, and half of them we didn't offer treatment to, or they didn't receive treatment rather. And again, this is not matched or controlled in any way, because the reason people didn't have treatment, for instance, would be because they were getting better already by the time we got around to seeing them, or because they did not have the capacity to consent to treatment sometimes. It was a mixture of reasons. But this is just the sort of the honest data of what our patients looked like for those first 18. And you see there's a huge range in the length of history of illness from a couple of weeks to many years of treatment. And they varied in the level of movement disorder, for instance. The minority had any abnormality on MRI or EEG, and only one person of the ones that we did lumbar punctures on had antibodies in the CNS, in the CSF even. But of those, the 9 patients that we did give immunotherapy to, all but one got better, dramatically so actually, and one who didn't was one that didn't manage to complete the treatment course of plasma exchange that we offered to them. But it's worth noting that in the ones that we didn't give treatment to, who received antipsychotics, half of them also got better. I should say the ones that got immunotherapy, we stopped their antipsychotics. So again, that was a sort of rather brave move 5 years ago, that we either patients didn't want to take them, or they had been so treatment resistant that we thought it reasonable to stop them. But it was a pure test of the immunotherapy versus antipsychotics in that group. So, and this is the profile of the antibody levels and the MRS in the 9 patients that we treated on the left there, just to show that the response to treatment with the MRS also did correspond to a reduction in antibody levels. And also that it's not entirely clear-cut, because some patients who didn't get treated also got better, and their antibody levels also went down. This is just an individual case history, just to sort of highlight, really, I suppose, the story behind using these very different sorts of treatments. So this was a young man who had a 3-year history of psychosis. It started with a paranoid persecutory delusions, but it rapidly developed into a prominent negative picture. So this was a guy who was a bit like David Fowler's talk this morning, but he was sat inside. He had extremely poor motivation and social withdrawal. He was almost entirely inactive and unable to look after himself, and very little speech. He had some white matter changes on his MRI, and he had frontotemporal slowing on his EEG. And he did have antibodies in his CSF when we started. So he had been treatment resistant to trials of 3 antipsychotics, and actually he'd just been started on clozapine when we saw him. So we gave him plasma exchange and saw improvement in his MRS it was a slow improvement over a period of 6 months, really. We gave him a further course of plasma exchange when we saw a deterioration at that time. And his antibody hasn't gone away completely, so it's come and gone, but his improvement has been sustained over 3 years now. And he's treated in a maintenance way with mycophenolate mofetil. So to take this forward, I just want to finish by telling you about our clinical trial that we are getting started with now. So this is hoping to answer more definitively whether immunotherapy is a useful treatment for antibody-positive psychosis. So we are going to screen a large number of patients to find those with these serum antibodies, and then we're going to randomize them to treatment either with IVIG and rituximab or placebo in a blinded way. And then our primary outcome measure is remission. So we're using Andreessen criteria. Our primary outcome is time to remission, which should be sustained over a 6-month period. So it's a highly ambitious trial, and we're going to need basically the whole of the UK's support to make it happen. And yeah, I'll come back in 5 years and tell you the results. So that's the summary. I suppose the converging evidence that a proportion of psychosis has an autoimmune basis. We think about 8.8% of cases will have these antibodies to one target or another. But they exist in control subjects as well. Studies to date using rather unspecific anti-inflammatory drugs in untargeted groups have only had modest benefits. And in our experience, immunotherapy is effective for those with antibodies, although we do need RCT evidence to really change practice. Thank you.
Hello? One of them. The other one. Thanks. Any questions, comments? Yeah.
Yes, I'd just like to ask a particular question about the measurement of receptors. We've had some
So this is about the assay, I think. Is that what you're asking? Yeah.
So we've had difficulties with people who've been a bit positive.
Yeah.
Yeah. Yeah.
Antibodies. The neurologists have been not interested.
Yeah.
And had arguments over a couple of weeks with an atypical presentation.
Yeah.
So I think you commented that now you're only using fairly high level.
Mm.
And is there some differences in the actual types of assays?
Mm.
Now, I think we can standardise some of those things.
Yeah.
Very helpful.
Well, it would be very helpful, I agree, yes. And I'm referring, Tom Pollock gave an excellent talk yesterday afternoon trying to cover this. There are major issues in the field about measurement. And yes, we use the live cell-based assay that we think is, we think it's more specific, but also it is more sensitive in picking up particularly low levels of antibodies. So you've got to be very careful at having a threshold that's likely to distinguish patients and controls. But I suppose my counter to neurologists is that they would treat somebody with an encephalitis presentation with a low level of antibodies, that actually it's the clinical presentation, it's the patient in front of you that's important, so that yes, you have the antibody to support your treatment protocol. But I was also hearing in Denmark that 50% of patients with encephalitis are antibody negative according to their testing methods. So, it is a little bit of double standards going on as well. So, yes, it's important to have an antibody test. Yes, it's important for the field to sort out, what is the gold standard for assessment. We haven't quite got there yet.
Time for one last quick question, if I may. If you want to come and get it.
Yeah. Yeah.
Could you just repeat that?
Yeah, so he's asking how often we look for tumours. So the original description of NMDA receptor encephalitis was in young women with ovarian teratomas. Since then, it's actually become much more unusual to find teratomas. So yes, it's part of our protocol that we do screen for those, but we don't look that intensively. We haven't found a single person with an ovarian teratoma, actually, or testicular.
Okay, thank you very much, Belinda. Now we're going to move on to the fourth and final talk by Michael Benros from University of Copenhagen, who's going to take some of these themes into a large-scale epidemiological context, I think. So, Michael.
Yes, thank you. Yes, my name is Michael Erik Benros, and I'm a medical doctor at the Mental Health Center of Copenhagen in Denmark. And I would like to first present some of our epidemiological studies on immune-related risk factors for schizophrenia and mood disorders. And then in the second part of the talk, I would like to display our meta-analysis of anti-inflammatory treatment for depression. And as we have also learned in the previous talk, the immune system have been associated with more and more diseases, hereunder also psychiatric disorders such as schizophrenia and mood disorders. And many diverse immune alterations have been observed in patients with schizophrenia and mood disorders, such as elevated levels of cytokines and increased autoreactivity. And also signs of dysfunctioning of the blood-brain barrier and signs of low-grade neuroinflammation have been found in subgroups of these patients. And recently also genetic studies have consistently shown associations between particularly schizophrenia but also mood disorders with the immune-related genes. And of particular interest also for this symposium is that immunosuppressive agents seem to improve psychiatric symptoms in subgroups of the patients. And first I would like to start off with some of our epidemiological studies where we use the entire Danish population as one large cohort, where every time we go to the hospital with an infection or autoimmune disease is registered in our registers, and then we can follow the people for subsequent diagnosis of schizophrenia and mood disorders. So in this study, we have a cohort of 3.5 million Danish individuals, which are followed during the period from 1977 to 2006. And during this period, there was 39,000 incident cases of schizophrenia. And people with an autoimmune disease had an increased risk of schizophrenia by 45%. But if you exclude the effect of infections, the risk were increased by 29%. And hospital contacts with infections increased the risk of schizophrenia by 60%. And as you can see in this figure, the risk of schizophrenia increased in a dose-response relationship with each number of infection the individual acquired. And here in the last blue bar, you can see people with an autoimmune disease and 3 and more hospital contact for infections. They have almost 3.5 times increased risk of schizophrenia. But as you can also see in the red bars, which are people that only have hospital contacts for infections, the infections in itself increases the risk for schizophrenia in a dose-response relationship. And the same pattern we also observed when excluding people with a substance abuse diagnosis or excluding people with a family history of mental disorders. And the association seems to be strongest with the temporal proximity of the last infection the individuals had. And here we had another study on a smaller cohort where we only looked at F20 schizophrenia as the outcomes and only on individuals born after 1981, where we have complete follow-up in the registers for all infections throughout their lifetime. And also here we show the same pattern with infections increases the risk of schizophrenia. And this was particularly true for bacterial infections. And then we move on to mood disorders. We have conducted a similar study where we have looked at the entire Danish population with 3.5 million individuals. And during our study period, there were 91,000 incident cases of mood disorders. And here we showed that autoimmune disease increased the risk of mood disorders by 45%, and a hospital contact with infections increased the risk with 62%. And also here there was a dose-response relationship. So in the last blue bar, which is individuals with autoimmune diseases and 8 or more hospital contacts for infections, they have an over 4 times increased risk of mood disorders. And again, the red bars are people that only had hospital contacts for infections, which increased the risk in a dose-response relationship. And this is number of hospital contacts. If we instead look at number of different infections treated at hospitals, people with 5 or different infections treated have a more than 5 times increased risk of subsequent mood disorders. And again here, the risk was increased the most with the temporal proximity of the last infection. So then we moved on and wondered whether some of this could be due to shared genetic factors with the Nature paper that Belinda showed, whether several genes coding for schizophrenia, and we used the polygenic risk score from this mega-analysis from the PGC. And in this Danish cohort of 1,500 individuals with schizophrenia and 1,500 matched controls that were all genotyped, we also showed the same relationships, that infections increased the risk with 55%, and after additional adjustment for family history of infections and mental disorders, the risk was increased with 42%. And then when we additionally adjusted for this polygenic risk score for schizophrenia, the estimates didn't change. So there seem to be independent risk factors. And also the polygenic risk score for schizophrenia didn't increase the risk of acquiring infections, which is also kind of surprising, I think. But there were independent risk factors, but also additive risk factors. So here we have divided the polygenic risk score for schizophrenia into 4 quartiles. So this is individuals with the 4 quartiles of most genes coding for schizophrenia. And the blue bars are people without infections. So people in the fourth quartile of the polygenic risk score have an increased risk of schizophrenia by 2.3 times. But then if they have had infections, the risk of schizophrenia is increased by almost 3.5 times. So they seem to have an additive effect, but there was no multiplicative interaction. So then, since infection seems to be independent risk factors for mental disorders, we also moved on to look at the milder infections treated at the general practitioners. And in Denmark, we have all infections treated with anti-infective agents is also registered in our registers. So here we looked at infections treated at the general practitioner, and of course the reference group is much smaller here because it's much more common to be treated with anti-infective agents. But if you had been treated with anti-infective agents, you have an increased risk of schizophrenia by 37% and an increased risk of mood disorders by 64%. And also the severity seems to matter, so people that had also had a hospital contact for infections had a further increased risk of the mental disorders. So the risk of schizophrenia were increased by 86%, and the risk of depression were increased by 2.4 times. And also here we show dose-response relationships with the number of prescriptions for anti-infective agents. And this graph is also adjusted for socioeconomic factors, parental educational level, and parental history of mental disorders and age and so on. And this dose response was particularly clear for mood disorders, which is the red bars. So you can see that people that have been treated for infections more than 20 times, they have a more than 3 times increased risk of mood disorders. And this is milder infections only treated at the general practitioners. So now we come to the second part of my talk, where we're going to talk about our meta-analysis from 2014 on anti-inflammatory treatment on depression and depressive symptoms. And here we also looked at adverse events. And in this study, we only included randomized placebo-controlled studies until 2013. And we both looked at studies on depression and studies on individuals with depressive symptoms. And anti-inflammatory agents could both be as add-on or as monotherapy. And here we identified 14 randomized controlled trials that we could include with over 6,000 patients. And 10 of these studies were with NSAIDs, and the studies totaled over 4,000 patients. And for the 4 studies at that point, that was randomized and placebo-controlled on cytokine inhibitors were only 4, but based on 2,000 patients. And here we show that people treated with anti-inflammatory agents that had a beneficial effects on their depression. And this is the overall effect with 0.34, which is a small to moderate effect. And over here we divided it in studies on clinical depression and studies on where they only measured depressive symptoms. And we can see that the effect was larger on the studies on clinical depression, where the effect was 0.54, which is actually above a moderate effect of anti-inflammatory treatment. Whereas the studies where the individuals only had depressive symptoms, the effect was a bit smaller, and it was 0.27 at that point, which is a small effect, but significant effect. And here we divided the studies into studies using NSAIDs and studies using cytokine inhibitors. And the above group is NSAIDs, and the effect of NSAIDs was 0.27, which is a small effect. And the effect of the cytokine inhibitors was 0.38, which is a moderate effect. And it's in line with the updated meta-analysis as well. But of course, these anti-inflammatory agents, they can also have adverse events, and it can increase the risk for gastrointestinal symptoms or infections or cardiovascular risk factors. So we included the information in the published studies on this, but unfortunately it was only 2,500 out of the 6,200 patients where this information was available. So we can only do it on that information. But in these studies, we found no significant adverse events, neither on gastrointestinal symptoms or infections or cardiovascular side effects. But we, of course, in the studies they have not reported it, we don't know about it. So to sum up these effect sizes, it was in the total effect of anti-inflammatory treatment of people with depression and depressive symptoms was 0.34. And if you want to make a sub-analysis with the compound with the highest effect, it was celecoxib when it was used as add-on to antidepressant treatment, where it had an effect of 0.82, which is actually a large effect. And actually in these studies I've also measured response rates and remission rates, and they had a 6 times increased response rate and a 7 times increased remission rates compared to placebo. So that's a pretty large effect. However, it's very important to mention that this was only in 4 studies on only 132 patients in total, so the sample there is very small. And on the cytokine inhibitors, the effect was 0.38, which is a medium effect. And in general, of the NSAIDs when used at monotherapy, it's 0.27, which is a small effect. And again, just to summarize, the effects on people with clinical depression is largest, so the effect was 0.54, whereas individuals that only have depressive symptoms, and most of these studies are people that have a somatic disease where they've measured it as a secondary outcome, the effect is 0.27. So, should we use this? Because many of these effect sizes are actually the same, and in some cases larger than antidepressants. And but however, when you used the Cochrane method for assessing the risk of bias, many of these studies actually come out with a high risk of bias. And this Cochrane method is, of course, the toughest method that you can use, and many of the antidepressant trials also would come out with a high risk of trial. And it's, of course, mainly that they can be characterized for profit bias, where there's interaction with pharmaceutical companies, and also the intention to treat analyses are often lacking in many of the studies, or not described in the studies at least. So we should still be cautious with the results. And one of the things we should probably do to improve this is to base future studies, of course, do them so they fulfill low risk of bias criteria, and also base them on inflammatory markers in the blood of CSF. And this is just to show that we just initiated a study where we are taking CSF systematically for patients with recent onset psychosis, and both CSF and blood are then stored in our biobank, and we hope to use this to actually develop the randomized control studies based on the inflammatory markers we found on this systematic screening of the individuals. So I'm looking very much forward to that, and this is our first patient that Sonia did it on. But the take-home message of my talk is that autoimmune diseases and particular infections are associated with increased risk of schizophrenia and mood disorders in a dose-response relationship. And randomized controlled trials with anti-inflammatory treatment has a moderate effect on depression and depressive symptoms. However, more high-quality studies are needed, particularly on patients with clinical depression, where most of the studies I presented were actually done on patients with somatic diseases where the depressive symptoms was a secondary outcome. And lastly, further randomized control studies on immunotherapy based on immune-related biomarkers is of utmost importance to the field. And then I would like to thank you all for your attention, and particularly thank all my collaborators. And Ole Köhler is the first author of the meta-analysis. And I also like to thank Marriott Nordentoft, who is also chairing today. Okay, thank you very much.
Thank you. That was great. Only you would describe a cohort of 800,000 people as small. Any comments or questions? Yeah, Paddy.
As a clinician, ECT works on a wide spectrum with a major disease. What do we know about ECT and the anti-inflammatory response?
Yes, that's a very good question. I've actually often wondered that. I'm not sure we know so much about it, but it would be very likely that ECT has an anti-inflammatory effect on the brain. I think there's some rat studies showing that ECT can have an anti-inflammatory effect, but I don't think there's any studies on humans. But I know we in Denmark are scanning people before and after ECT in a new trial, where it would hopefully be possible to see if it can affect some inflammatory parameters. But it's a very interesting question.
Thomas.
Wonderful series of analyses and papers. I'm just wondering, can you rule out reverse causality? Can you rule out the possibility that patients who eventually develop, for example, schizophrenia, may have an immune system to start with that is different, and therefore the probability of infection is higher in those patients? And to some extent, it's probably answered with your polygenic risk score, because I think you said there is no relationship between polygenic risk score and the probability of infection, right?
Yeah.
So, any other thoughts?
Yeah, I think I would actually I thought myself that there would be a relationship between the polygenic risk score for schizophrenia, either because they have a dysfunctioning immune system or so on, and also maybe they are more socially disabled, which would make them more likely to acquire infections. So I was surprised that it was no association at all, not even a tendency. So, but we are going to follow the study up where we are looking at specific immune-related genes in this cohort to see if they can explain some of the associations with infections and autoimmune diseases. So utilizing, we're developing our own immune-related scores on this Danish sample. So that might explain some of the associations. But based on the information we have now, both for the PRS for schizophrenia and also for the autoimmune disease consortium, there's not much overlap there indicating that that is the reason. But yeah.
Last question. Hang on a sec.
Based on some of this, what would you include in a routine screening for someone with a new onset of psychosis?
So a routine clinical screening for first episode psychosis.
Yeah. I think, the first thing, of course, the basic analysis with cells leukocyte in the CSF, which should not be elevated in the individuals, but also markers of increased blood-brain barrier permeability with the albumin quotients and the IgG index also, which can be used to that. And of course, CNS reactive antibodies in the CSF and also in blood, which are the things that we can probably use now in the clinics together with the oligoclonal bands, which is a marker of some brain injury. And then the rest we are saving for research purpose, so we can hopefully do a larger panel in the future. But for now, we only have the things available to us from neurology, I think.
Okay, we better finish. Just before I thank people, the title was a question. So who thinks this area is a blind alley? And who thinks it's a promising new lead? Okay, that's nice. Well, thank you to all the speakers for those presentations and to Marriott for being co-chair. Thanks very much, everyone.